We're always looking for a cure. And so the first thing that I always tell owners is that if you're talking about curing a dog, you have to be willing to accept some of the toxicities that will occur from the total body radiation. Those toxicities are expected. We've learned through the years how to manage those very appropriately. And so it's important up front for folks to understand that.
Welcome to the Veterinary Cancer Pioneers Podcast, the show where we delve into groundbreaking work of veterinary professionals who are dedicated to advancing the field of veterinary oncology. I'm your host, Dr. Rachel Venable, and I'm thrilled to embark on this journey with you. Hello, and welcome to the Veterinary Cancer Pioneers Podcast. I'm your host, Dr. Rachel Venable, and I am so excited today to welcome our guest, Dr. Steve Suter. Dr. Suter has a DVM and PhD and is board certified in veterinary oncology. He did his training at the University of Pennsylvania as well as UC Davis. He has been part of the North Carolina State University faculty, and he's ran the world's only academic canine apheresis and bone marrow transplant unit, and training specialists through a dedicated fellowship program with that. So really interested to dive in deep and learn more about the bone marrow transplant program. He has over 60 scientific papers, book chapters, and a frequent speaker internationally and locally at different conferences. So also very excited with that. And he just started the Canine Transplant and Apheresis Center in Chattanooga, where he's going to be offering those services as well. So Dr. Suter, thank you so much for being here today. And I'm really excited to learn more about just your bone marrow transplant program and the apheresis, everything that you've been doing.
Well, thanks so much for having me, Rachel. It's great to be here.
Yeah. And, I always like to start with just kind of what led you into veterinary oncology, and certainly for you, what got you into bone marrow transplants?
Well, it was a pretty long journey, to be honest with you, and I sort of fell into it backwards. I ended up working on a PhD when I was doing my veterinary degree and PhD at Penn, and the project involved the use of gene therapy in combination with bone marrow transplant to treat puppies with a severe combined immunodeficiency. The disease was called XSCID. And during that work, I had to dive into the transplant literature, which is all in the human side of things. So there's a ton of literature in the human field on bone marrow transplants, and quickly found out that dogs were used as a model for bone marrow transplants by mainly the Fred Hutch Research Center in Seattle for close to, at that time, about 40 years. Now it's about 60 years. And I had no idea that literature was out there. I had no idea that you could transplant a dog. I had no idea that dogs are used as a model. And so it really opened my eyes during my PhD research that this was something that was possibly available for veterinarians. So again, I sort of fell into it backwards while working on another project that involved transplant. I had never been taught anything about transplant in veterinary school, as we're still not, and I had no knowledge whatsoever of how to do it. I was really a clean slate.
Sometimes that's the best way to start, right? When you're not coming in with any preconceived notions, just doing it. So what would you say, kind of comparing chemo with bone marrow transplant, long-term outcome? I guess, can you just sort of walk us through the bone marrow transplant process? Maybe just for some of our listeners that aren't as familiar with it. So when do we use it in dogs, and when, so what diseases and at what point do you recommend it?
Yeah, so it's really bone marrow transplantation is really a combination of chemotherapy combined with a bone marrow transplant. And so it actually is not one or the other, it's a combination. So it's I would consider it a pretty aggressive approach to trying to treat dogs with lymphoma or leukemia or some other myelodysplastic disorders of the bone marrow. And so all dogs who undergo a transplant have to receive chemotherapy first, which is what you and I do every day, is give dogs chemotherapy. And so the goal is to drive them into clinical remission with chemotherapy first, hopefully. We'd like to have that, and that's always the ultimate goal. So using chemotherapy for a amount of time, and we can talk about that a little bit later, to drive these dogs in remission, to cytoreduce them, to get the tumor burden as low as possible. And most folks, I would imagine, who are listening to this podcast are aware that we rarely cure dogs with chemotherapy. We can drive them into clinical remission, but we can't drive them into molecular remission. And so that lack of a molecular remission is what gets dogs become resistant to chemotherapy eventually. So we're really using bone marrow transplant to drive dogs into molecular remission after receiving high dose chemotherapy to drive them into a clinical remission. So when a dog's in a clinical remission, there still has some cancer cells floating around somewhere. We don't really know where, to be honest with you, or how much, but they are clinically doing well. So that's really the combination of that. Any dog who gets into a remission with chemotherapy is then a candidate for a bone marrow transplant because they've been cytoreduced as far as they can. Now, it sort of depends on the transplant type, which maybe we'll talk about in a little bit. But theoretically, the best case scenario is a dog having high-grade lymphoma in clinical remission with chemotherapy, and then we're ready to go.
And as far as getting them into clinical remission, do you have a particular protocol that you like vets to use, or could it be anything as long as they go into remission? How do you typically recommend that beginning step?
Yeah, the answer to that is yes. So, we all consider CHOP to be the best chemotherapy protocol because it's multi-agent and leads to the best results in a wide variety of studies. So most folks will use CHOP, but it really doesn't matter to me what protocol is used as long as they do go into remission. Now, for an autologous transplant where we're using stem cells from the patient, we tend to be very careful with the amount of cytoxin, cyclophosphamide, those dogs use. That's the C in CHOP. Because those dogs receive a very high dose of cytoxin before transplant for a variety of reasons, and we don't want resistance to that particular drug. So we tend to leave out CHOP and just use HOP instead for those dogs. But many times we don't know if a dog's going to make it to us or not. So I can't say that those dogs who have received cytoxin do worse in a transplant setting than dogs who don't. However, because of the issues of resistance, I tend to avoid that in the CHOP protocol. But any protocol is fine as long as they're in remission in general.
Do you have a way to determine molecular remission? You mentioned clinical and, it's usually feeling lymph nodes and imaging or things. It's not real precise. But do you guys have a certain way that you're looking at molecular?
The only way we have is really with PAR, PCR per antigen receptor rearrangement. So before the dogs undergo a transplant, we do run PAR on their blood. And if we have recent bone marrow to make sure we can't find any cancer cells in there. Now, that depends, of course, if a dog has a PAR positive tumor when they're diagnosed. And so that's always nice information to have, because if they have a PAR negative tumor, then running that PAR at that stage of the game is really not going to help us. And then if they have a PAR positive tumor, we also run PAR on the apheresis product, which we'll talk about a little bit, to make sure that we haven't harvested any cancer cells in their apheresis project, which we would obviously give back to themselves, which would not be good theoretically. So that's really all we have. It's a lot of dogs, we don't have PAR results or they have PAR negative tumors. So it's a little bit of a guessing game.
As far as PAR, can that just be done on lymph nodes, or would you want a bone marrow? Like if you have an owner that wants to do everything, or you're hoping this dog can do a bone marrow transplant, should you do that in the beginning, or is that something they can do when they come see you?
Usually we'll do it when they come see me, but we've really, through the years, I've been transplanting dogs since 2007. When I say we, I guess I mean me, but I always say we because I always have a big team to help. But we sort of backed off on PAR bone marrow, or even analyzing bone marrow from the dogs who come to us in remission, because in the beginning when we did it, those dogs we never found any disease in their bone marrow when they were in remission. So I sort of backed away from that through the years. However, if I have a dog that I'm obviously worried about some disease somewhere, then we'll go ahead and do that. But we tend not to even do bone marrows on dogs anymore when they come to us when they're in clinical remission. So there's no obviously tissue to analyze at that point.
Okay. And how should veterinarians determine if a dog is a good candidate for bone marrow? Is it just after they go in remission of CHOP, or is there something to decide in the beginning?
No, there's really nothing. The main criteria is really dogs with high-grade lymphoma, whether it's B or T, or leukemia, which of course is super high-graded, nasty, and scares everybody. And the fact that they have responded to chemotherapy and have gone into remission. That's really it. We do worry about comorbidity. So, of course, these dogs, a bone marrow transplant, just like in people, does stress the system a bit. And so we worry a little bit about other comorbidities, such as advanced heart disease or other endocrinopathies or histories of seizures and stuff like that. Not that I wouldn't transplant those dogs, but we really want to know about those ahead of time so we can pay particular attention to them. And so many times dogs will come to us with, grade 3 murmurs or something like that with no echoes. And we'll do echoes on them to make sure that everything's structurally okay with their heart, stuff like that. If they have Cushing that's out of control, we'll try to get that under control, et cetera, et cetera. Sometimes we just never know what we're going to get until the dog arrives. And so it can be surprises sometimes.
What should you, or I guess, what should we as the veterinarians, kind of prep owners for doing a bone transplant? Like, what should they be prepared that, okay, you're going to go to North Carolina State or Chattanooga and this is what's going to happen?
Yeah, it's actually quite an education process. So I like to be extremely transparent with everybody, including the owners and the referring veterinarians, about what the expectations are. Number one is that we're talking about a cure, period. And that's the whole goal of this. Some life extension over chemotherapy alone is also possible, but we're always looking for a cure. And so the first thing that I always tell owners is that if you're talking about curing a dog, you have to be willing to accept some of the toxicities that will occur from the total body radiation, because that's what we use for trying to kill every cancer cell in the body for an autologous transplant. And there are side effects from that. And for any medical oncologist listening, those side effects are just exactly the same as a very high dose of chemotherapy. And so they can have GI toxicity. Some do, some don't. Some can be significant and some you can never know. And bone marrow issues. And so those toxicities are expected. We've learned through the years how to manage those very appropriately. But it is total body radiation. It is lethal without a bone marrow transplant. And I think we have a pretty good protocol now in place where we don't lose dogs. But there's always that potential. There's just a potential that something could go wrong, and that would be lethal, quite frankly. And so it's important up front for folks to understand that. And then the other thing we always explain is that it's a process. It's a series of 5 different steps that are done sequentially to get a dog through this. And so if something happens in that sequential process, there is a possibility that a transplant may not happen. Now, it's very rare, but we always talk about everything that could happen bad, so everybody knows what's going on ahead of time. Those are rare, but it could happen. It happens to people when they go through a transplant process. So those are 2 really important things that I think folks should know, both referring veterinarians and dog owners.
And how long does this usually take? Like, is it something where it's normally more local people that come and do this versus people traveling across the country? Like, is this something that takes a week? How long would the pet owner or the pet need to be there?
Yeah, so it takes, the whole process takes about 3 weeks or so. The actual transplant itself only takes 3 days. And so if we can talk about the protocol now or later, the dogs arrive, we start the transplant process on a Monday. We're actually usually done Wednesday or Thursday. So that actual process of transplantation doesn't take that long. What takes longer is for the dogs to go through the toxicities of the radiation, which is, of course, as I said, GI. And really what we pay attention to a lot is bone marrow, because their bone marrow is essentially killed by the radiation. And we have to wait for the transplanted cells in the dog to start doing their job and making the cells they need. And that can take a week or 2, kind of depending on the cell line we're talking about. So they end up being in the hospital around 3 weeks or so. The first part of the protocol, they're just receiving Neupogen under their skin, which is a drug that makes their white blood cell count go very high and drives stem cells from their bone marrow to their blood. And at that point, they're not in the hospital. So Thursday to Sunday, they're just getting twice daily Neupogen injections, and we're just checking their CBCs. And then they're admitted into the hospital on Sunday. We do the process, the bone marrow transplant process, which is usually done Wednesday or Thursday, kind of depending on a couple of factors. And then this becomes a waiting game. We put out brush fires, for lack of a better word, support them with whatever medicines they need for their GI tract, and give blood products if needed for their cytopenias post-TBI. And once their neutrophils come up and their platelets come up, they go home. But that whole thing all strung together takes about 3 weeks. As far as local versus national, we have had dogs at NC State come from Canada, California, Florida, New York, all over the country, Cleveland. We've actually had a lot of inquiries from overseas folks. We're working on a dog from Spain right now at CTAC. We've had a donor dog come from England for an allo transplant to donate cells. So it really is turning into an international effort.
It's really cool. And you just mentioned, the allogeneic. So can you kind of tell us the difference between the autologous and the allogeneic transplants?
Yeah, it's actually quite interesting to me. This is why I find everything about transplant so interesting. In an autologous transplant, which is what's usually used for folks, for people who have had lymphoma and have relapsed, that people receive R-CHOP, as you know. Unfortunately, we don't have the R right now. But those people who have received R-CHOP and relapsed, they undergo an autologous transplant. We use it in a little different setting in dogs. We use it in what's called an upfront setting. We don't wait for those dogs to relapse. We do the transplant before relapse, as I explained earlier. And so an autologous transplant is really where we just take the stem cells, the hematopoietic stem cells, from the dog using an apheresis machine after 4 to 5 days of Neupogen. And we harvest those cells from them from the peripheral blood, which is why we run PAR, as I said, on the peripheral blood to make sure that there's no cancer cells in there. So we take those cells out of the dog, which is actually quite easy with this apheresis machine. And then they receive total body radiation. And that's going to obviously, quote, kill their bone marrow. It doesn't really kill it, but it certainly knocks it down hard. And we're hoping at that time, the radiation will kill every cancer cell in the body, everyone. And that's a hard task, but it can be done. After that radiation is done, we just take the product that we harvested from the dog before the radiation and just put it back into them. And that's it. And so that's called an autologous transplant. Then those stem cells, hematopoietic stem cells in their own blood, they go in the veins and they go into the bone marrow and say, oh, here's our home. We know this. And then they start making the cells that they need for the dog to stay alive. So that's an autologous. An allogeneic setting is where we use stem cells from a matched dog. And so, again, in humans, there are public banks where if I developed, let's say, leukemia, and I needed an allo transplant, and you had donated cells, and you matched me, then they would ask you to come and donate your stem cells using this apheresis machine, and I would use your stem cells to be donated to me, and then I would be transplanted with your cells. So in that setting, that's called an allogeneic transplant. Unfortunately, we don't have public dog banks for stem cell sequences, and so we have to do it a la carte, is what I like to say. So for a person who has a dog who wants to undergo an allo transplant, we have to find a match. It's called a DLA, dog leukocyte antigen matched dog, to donate those cells. And all those dogs are usually litter mates, or the bitch and the sire, or dogs from that same mating pair. They all have a 25% chance of matching, and it's not additive. And so each dog is a separate 25%. But if we can find a match, which we do most of the times, actually, if people have purebred dogs and you can track their progeny, those dogs are then given Neupogen. We harvest those dog cells. And then after the total body radiation, we put those dog cells into the dog with cancer. Now, with the allogeneic transplant, we use less radiation. So auto dogs usually get 10 to 12 gray, which is just like a prescription of a drug. In allogeneic dogs, we give 8 gray, only 8 gray. It still is really tough on the bone marrow. And it's really not designed to kill cancer cells in the body, some of them, but not that higher dose with an autologous transplant. We just want to make space in the bone marrow for these new foreign cells coming in. And we want to provide some level of immunosuppression until those allo cells, those new cells, can get into the bone marrow and say, oh, here's our space, but it's not really our home. It's the new home. And what we're going to do is put these dogs on cyclosporin, which is an immunosuppressive drug, so that the graft is not rejected. But we want graft versus host disease. The reason we want graft versus host disease, that's the graft, the tumor, saying to the host, I don't like you very much. That's a bad thing. But in the setting of lymphoma or leukemia, it's actually a good thing because you get secondary graft versus tumor effect. And so that's the first form of immunotherapy that's ever, for lack of a better word, invented. And it's extremely powerful. And so we want some graft versus host disease, but we don't want to make so much that it makes a dog ill or possibly dies, because graft versus host can be very difficult. But we want that because we want a good level of graft versus tumor effect. And that's why this is such an interesting process, because we're sort of walking this knife's edge, for lack of a better word, using suppressive drugs like cyclosporin to keep the GVHD down, but not enough that it's not going to get graft versus tumor effects. So we kind of play this game between graft versus host disease, making a dog ill, but we also want graft versus tumor effect. And the point of that is, so you say, well, why in the world would you do an allo when you're talking about all this crazy cyclosporin and graft versus host disease, because it's extremely powerful. And so the cure rates, even in the early studies that I've done with small numbers of dogs, are over double for an allo transplant than an auto. And so that's why it's used in people, because you can cure a lot of people who relapsed after receiving RCHOP. You can cure a lot more people with an allo. Again, people live for a long time, and so you have to worry about graft versus host in people. Nevertheless, it's a very powerful form of immunotherapy that I'm really excited about, actually.
It does sound like you have a lot of moving parts when you're doing all this. It's a lot to keep track of, but it is really fascinating. And I never really realized with the allogeneic that you wanted some graft versus host, that you were saying getting that immuno response to the tumor. So that's really fascinating. So, but like you said, really the only option with that in dogs is if you know the mating pairs, like so for pure breeds, because otherwise just, if you got a dog at a shelter or rescue, just trying to find another match, is it almost impossible?
Yeah, it's almost impossible. Yeah. So we always shoot for an allo. And if we can't do an allo, then we'll go backtrack to an auto. The other really interesting thing is there's no way you could transplant, let's say, a golden retriever with a Siberian husky cells. You can't go cross breeds because these breeds are such genetic islands that it's at this point would be it's impossible, because you would get such massive graft versus host disease. You could never control it. We, as humans, we're all mutts. And so we have a lot of intermixing. And so it's not that hard to find a match. It usually takes about 2 weeks in people, maybe 3. But in our world of purebred dogs, it's really, really pretty much impossible. So you're right. You need a same breed, and you need to be able to track down those pups and the bitch and the sire. And if you can't, then an allo really at this point is not an option.
Yeah, that's really fascinating. And it sounds quite the process, but really interesting on how, all the different steps you have to go through. So I'm assuming that this is pretty expensive. How do you balance cost, or what do clients, are a lot of them using insurance? How does that whole process work?
Yeah, so it is expensive. And so I remember back when I started in 2007, and one of our cases hit $20,000. And I was like, it's just, oh my God, I can't believe how much money this is costing people. But as it turns out, in at least our chemotherapy here at NC State's kind of on the cheap side, but in private practice, you can spend $10,000 to $15,000 on chemotherapy, especially these days, as things are a little bit crazy, of course, really easily. So you can spend a lot of money on chemotherapy for a protocol that works. It really does work. Chemotherapy really extends dogs' lives, but it does not cure them. And the vast majority of them relapse, of course. I mean, everybody who does medical oncology knows that. So it is a very pricey item. It's pricey at CTAC. We're a startup. And so we're quoting people $50,000 to $70,000. That's a lot of money. The good news is that it is covered 80 to 90% by most major insurance companies. Way back when I started all this, it took me about, I don't know, maybe 4 or 5 years to convince Trupanion at that point that it was not experimental. That was really their issue, is that they're not going to pay for something experimental. And finally, I convinced them through sending them papers and talking to them, papers that I'd published, that it was not experimental, it was actually clinical. And they started covering it. And so a bunch of other insurance companies fell in line. Now, most of the major insurance companies pay for bone marrow transplant. I hope that continues. We'll have to see. But so that helps a lot, obviously. A lot of people have used social media to raise money also, which has been really nice. Just have a bunch of folk using social media. And so people seem to be able to come up with the money many times to do that. We have a third party, a vendor at CTAC, who is supplying folks with money as sort of a loan. I don't know the details of that because I'm on the medical side of the company, but we do have a third party that is helping people with their finances also. So it is expensive. There's no doubt about it. And it's certainly not for everybody for a variety of reasons.
That's great that you've got insurance to help, cover this, and people using social media and other groups. So, and good for you for being persistent with insurance.
Yeah.
Because that could be a challenge. So thank you for already doing that for the rest of us.
Sure. I always say to folks, if you have a purebred dog, which a lot of people do, and you should get insurance day one, you get insurance day one, because you and I both know that we see mainly purebred dogs in our cancer clinic. That's for sure.
Yes, we definitely do. And with all this, and like you said, it's not for everybody, but it's certainly still a good option. Do you have any kind of stories that stick in your mind of different cases that you remember doing? Or I'm sure that first case you did was probably pretty memorable.
Yeah, I have about 157 stories. There's so many dogs I've transplanted. And so each family is a really unique situation. The first dog that you mentioned was a dog named Tina. She was a chow, and she was 12 years old. And she was owned by a gentleman who was in the medical field. He sold medical equipment. So he was actually quite well aware of the whole scene, of transplant scene. And I sort of talked to him and said, she's 12, she's a chow. This is a big ask for her. And his previous chow chow had lived to be 16, which is great for a chow chow. And so he was all in from day one. He just wanted to do it. And we transplanted her, and I was beyond nervous because it was the first dog. We were in our old hospital. We had to sort of make an isolation ward out of the runs. It was a sort of little bit ghetto, but that's okay. We transplanted her, and she actually did great. She engrafted beautifully. She only bit me twice, which I thought that was pretty good for for a chow. I'm pretty sure they were lump bites. And she left and went home, and she ended up, unfortunately, developing liver cancer about, I think it was 12 months later or something like that, and then succumbed to that. But she didn't die from lymphoma, and obviously she didn't make it to be 15 like his previous child. But he was really happy about it and felt that she had a great quality of life at home. So that was sort of nice. And there have been a lot of other great stories. There's so many. We've had dogs one dog who's still alive, Quinoche, is a service dog for an autistic woman. And he knows how to read sign language, actually. And so he developed lymphoma. He's a big old mastiff and sweet as can be. And he underwent an allo transplant and is still alive to this day. And so he's still doing his service for his owner. So I think that's pretty fantastic. He's an interesting case. We've really never been able to get him off cyclosporin completely. We usually leave them on cyclosporin for about a month, and then we just stop it and sort of see what happens. And every time we lower his cyclosporin dose, and this has been almost 4 years now, his liver enzymes start going up. So the liver is one of the GVHD organs in dogs. Alkaline phosphatase is really the one we look at, and T-billy on chemistries. So every time we lower his dose, they go up again. He still feels fine, but it's an indication there's a little bit level of GVHD there. So he'll probably be on cyclosporin low dose for the rest of his life, but he doesn't care. And his owner certainly doesn't care either because he's still with her. So that's always been a really heartwarming story also. Probably the last one I'll mention out of all of them is the dog who was owned, Millie. She was owned by a very nice couple in California. And we found a donor, but the donor lived in England. And so they brought the owner and the dog to the States here at NC State. And they met here for the first time. We have lots of pictures and got to know each other. And so Millie was transplanted with, I forgot the dog's name, from the UK, unfortunately. And she's still alive to this day, living in California. And so that was really kind of fun to see something like that happen. That's, these people are so darn dedicated. It's amazing. So you can imagine what went into all that, not only the money, but also the effort to find a donor and then figure out how to get the donor here. And it was a lot. And these folks are just my heroes, to be honest with you. They are so dedicated to their pets.
No, those are amazing stories. I love that. Those are great. And just all the different ways they come together and how well they're doing. One thing that did come to mind, you have been talking about cyclosporin, and I understand the use of that for the graft versus host, but also, I feel like there's always a warning label with cyclosporin that potentially could cause other cancers, or normally I'm careful with it. So why is it, I guess, that you guys aren't seeing any issue? Is maybe that warning of it causing other cancers maybe not totally founded? Or is it just because you're doing bone marrow transplants, so it's totally different than if we were using cyclosporin in a different pet with cancer? What are your thoughts on that?
Yeah, I know that warning for sure, because it always worries me. But typically these dogs are on a very short course of cyclosporin. So usually they're on for a month. So we'll leave them on a month post-transplant. And then once they're fully engrafted and they go home, we'll stop it and sort of see what happens. As I said, the GVHD organs in the dog are the skin and the liver. And so if we stop it and there's no liver enzymes and there's no skin crusting and scabbing, usually around the eyes and everything, then we're good to go. If they start having elevations in liver enzymes or T-billy and skin issues, then we'll put them back on that for a while and then try to wean them off that in a slower process rather than stopping, which almost always works. And so it's a very rare dog that needs to be on cyclosporin for a long time. I do worry about Quinoche because he's been on cyclosporin for a long time. but it's a super low dose that seems to control him. And so, I mean, he has a fatal cancer, and if he relapses with disease, he's done. And so I think it's worth the risk. Any of the allo dogs that we've done, most of them are off cyclosporin fairly early, so I don't really look at it as really a big risk, to be honest with you, in those dogs. And the dogs who are on a really long time, I worry about it. But again, what's the alternative?
Oh, that's very true. And that is fascinating. But it's interesting, too, for me to hear that you haven't seen any issues. So that is interesting, just using that drug. And so I am curious about the group in Tennessee. So what made you open a branch in Tennessee?
Well, it's a little bit of a dicey story, I guess. The transplant program here was shut down, unfortunately. And so this was basically my whole career here at NC State has been research related to lymphoma, but also on the clinical side has been transplant. So I've been transplanting dogs for a long time, since 2008, actually, with a couple breaks in between. And it was just an administrative decision to shut the unit down. It was after a very, very difficult case of a dog who had acute myeloid leukemia. Anyway, that dog ended up dying in the hospital, and a decision was made that the unit should be shut down. So I was quite upset about that, quite frankly, because that's crazy talk, but that's the way it is sometimes. And so I ended up, when I had a transplant unit here, I trained fellows, as you mentioned earlier. And so I had 7 fellows who came. Initially it was 1 year, and then we made it into a 2-year fellowship, and it was a fellowship in apheresis and bone marrow transplantation. And so my goal of all of this has always been education, because that's what I had to be educated to learn about all of this. And I had to do it myself, which is really a pain in the you-know-what, because I didn't know anything. So my goal also was always to train folks to come to NC State and learn this, and then go out and transplant dogs. I mean, I can transplant, 24 dogs a year, maybe 30 tops, because I have so many other things to do as far as being an academician. So I always wanted to train folks and have them go out and then start transplant units, or at least educate medical oncology, all veterinarians and owners about this. As it turns out, one of my transplant fellows' name is Dr. Alexander Garreau. She was here for 2 years. Then we kept her on for a medical oncology residency for 3 years. And then she was on faculty for a year. So we had her for a long time. As it turns out, she took a job in Tennessee at this practice. And also it turns out is we had a radiation oncologist resident here named Jason Strasberg, who works there also. So that means they have a linear accelerator there. Obviously for transplants, you have to have an accelerator and a radiation oncologist for TBI. And so she went there, Jason was there, and everybody started talking. And as it turns out, there was a couple there who owned the Pullen Cancer Center, and they became very interested in transplant and apheresis. And so that's where the germ sort of started to grow, the seed, I should say, not the germ. And so then I got involved because I got very excited, because I've actually always wanted to expand this beyond NC State. And so that's how the whole thing started. And it took a long time, probably about 1.5 years or so of negotiations and trying to figure out what to do. And we literally started with a big giant room that was just a big giant room, huge room. And we built it from the ground up, put in isolation wards, runs, an apheresis. We had to get an apheresis machine and all that. So it cost a fair amount of money. And we started accepting cases in January. We have our first one on April 24th, I believe. So we're just getting started. So it's quite exciting. And I'm really happy to be back in the game, for lack of a better word. It's a little awkward because I'm still here at NC State and I don't live there, but I've been involved in building a unit and advising the group on, the protocols and all that. So I'll be there for probably the first 5 transplants, just to oversee everything. And Alex is well trained because I trained her, and so she should be fine. Yeah, but so we're all quite excited about it. But it's a startup, and we have to make some money to stay open. So we'll see how that goes.
Well, it is exciting. And it's probably, like you said, fulfilling for you, just because you always training people. This is what you're wanting to do, and really getting to see it come out, right? And you can help kind of oversee in the beginning and things. So that sounds really exciting. Are there other areas just that you are aware of in the country that do bone marrow?
There's only one. There used to be quite a few. There used to be about 4. But there's only one left. It's Dr. Ed Sullivan in Bellingham, Washington. He's been transplanting dogs as long as I have. Actually, he started before I did. And he had the first paper way back in 2006 where his group, which is a private practice in Bellingham, transplanted a dog with an allo transplant with T-cell lymphoma way back when. That was a long time ago. And the dog was cured of its disease. So he's been a pioneer also. And I talk to him all the time. And we've worked together on these transplants a lot. So he's got the West Coast covered, and I've got the East Coast covered so far. Yeah. So that's the only other option. So we still get a lot of requests for transplants, or at least to talk about transplants here at NC State over the past 2.5 years that I've been closed. So I've been sending all those cases out to the West Coast.
Very cool.
So that's it. There's only 2.
Yeah. Well, at least they're on opposite ends of the country. So that does help a little bit.
Our goal is to get this up and running and then open some other sites, either across the country or across the pond, as they say. We'll just have to see how it all goes. But we'd like to have more than just one site because as you know, there's thousands and thousands of dogs coming down with lymphoma every year across the world, probably tens of thousands. And so hopefully we can help those dogs. That's what this is all about, helping those dogs.
Yes, I've definitely heard some big numbers, like 70,000. I mean, nobody quote me here because I can't remember the source, but yes, there's a huge amount every year that are diagnosed with lymphoma. So, and a lot of how we treat it hasn't changed much in the last few decades, where people are looking into things. So it is exciting to hear about other options. And if clients are interested in this, or, as a vet, if you're thinking you have a pet that would be a good candidate for this, how do you go about this? Do you call a clinic? Is there a website? I guess, what is the way to kind of get things, started if you think that pet would be a good candidate for a bone marrow transplant?
Yeah, the easiest way is to go to the CTAC website. It's just CTAC. And just put CTAC Tennessee and it'll come up. And there's a portal there for veterinarians and for dog owners to ask that they want to be contacted. We really, really, really like talking to owners and veterinarians. And so we always like to talk to them first and make sure they understand the whole process, make sure that they understand the money involved. We actually have a really nice owner handbook that we like to send to owners. So there's a ton of information there written down. So it's nice to read something. I'm still old school, so I still like to look at a piece of paper, but it's web-based also. So we send them the handbook. We have a handbook for the donors, for potential donors also, so they understand if their dog does match, what's involved in the donation process, which is benign, but it's still a big deal for dog owners. And so we have that handbook also. So we send that to them. We have the owner handbook we like to send to veterinarians also. So we would send that to, let's say, you, so you could look at that and go, oh, what the heck's this cyclosporin deal all about? So just general information. And so we just start a communication process first. And that's extremely important that everybody understands what expectations are set. And then if the owners are interested now, if they say, oh, I know where there's, 5 siblings, they live right down the street. Well, of course, then we'd say, all right, well, let's get a tube of blood for them if you're interested, and we'll get the sequences, the DLA sequencing done. We still do it at the Fred Hutch Cancer Research Center. That can take a while, so we'd like to get on that right away. And so we just start that whole process there. If it's not going to be an allo transplant, then we start talking about approaching it quicker, because I'm a paranoid oncologist, which you probably are too, and I always worry about relapse, especially with T-cell dogs. And so an auto, we tend to get on much quicker because we don't have to wait for the owners to find potential litter mates, and we don't have to get the matching process done. That whole process can take many months, many times. With an auto, as long as the dog is on chemo and either in remission or getting close to remission, we really like to get on those quickly. My initial data shows pretty clear, which is exactly opposite of people. The dogs who have relapsed with disease don't do that well with an auto transplant, which is really interesting. So the upfront auto transplant is actually not used in people at all, because you can cure 60 to 70% of people with a R-CHOP. So you never put a person through a transplant, which really stresses the system and has a potential for death when you can cure that higher rate with R-CHOP. It's been exact opposite in my experience. However, again, my manuscripts were not 400 dogs, which is what we really need. Mine were, 15, 24 dogs. And so again, that's another point of having multiple sites, is to get a database. We're actually building a database to try to say, this is the cure rate for dogs with high-grade B-cell lymphoma using an auto and an allo transplant. The rates that I published, I don't know if they'll stand. I hope they do, but I don't know. We haven't transplanted enough dogs. So we're in the process of building that database to be able to say with more certainty the benefits of this or not. I think there are benefits, but we won't know. That was a rather long-winded answer to your question.
Totally fine. Totally fine. And I was just going to ask, what are those cure rates and benefit rates? What are you guys seeing so far?
Yeah, so for a dog with high-grade B-cell lymphoma transplanted with an auto transplant, the cure rate is defined. You have to remember, most of the studies in the veterinary field don't follow dogs for years in the studies. They're 1 year survival, 2 year, et cetera, et cetera. So the cure rate in dogs is defined as living greater than 2 years past transplant. Why did I pick 2 years? That's because it seems that the dogs, I've been doing this long enough now, the dogs who live 2 years post-transplant don't relapse. And in people, that line is sort of 5 years. And so again, everything happens quicker in dogs, and so 2 years. For dogs who have diffuse large B-cell lymphoma transplanted with an auto transplant, that is around 30 to 40%, somewhere in that range. The first manuscript was 30. I've published the second one using this other immunotherapy that not important what we're going to talk about. That was 40. So it's somewhere between 30 and 40. So that's cured. Those dogs go on to live a normal life. With an allo transplant, the publication that I had in VCO, it was 90. Now, that's a lot, and that's fantastic. But that was, again, it was a smaller number of dogs. If it holds up after transplanting 200 dogs, that would be fantastic, but I don't know if that number is going to hold. But even if that 90 drops to 70, that's still way better than chemotherapy alone, which is 0-ish to maybe 2%. So that's a B cell. T cell still remains a problem. It remains a problem for you and me with chemotherapy and everybody else out there. So the cure rate of dogs with high-grade T cell lymphoma with an auto is down around 20%. And one could argue that's not worth the money. And I've heard that argument before. And I don't know if that argument's valid or not. But I can tell you, if you talk to those 20% of families whose dog is still alive, who were given a death sentence when they found out that the dog had T cell lymphoma, they're pretty happy. So, I guess it depends on how you look at it, glass half full or glass half empty. We haven't published our data on the allo transplants yet. We're looking at that. I think it's going to be around 50% for dogs with high-grade T-cell lymphoma at first look, but I'm still collating that data. We have a couple of dogs we're waiting on to hit that 2-year mark right now. It looks like if those dogs make it, it's going to be around 50%, which would be fantastic. And so those are the numbers we have at this point. And again, we just need a lot more dogs to really say definitively what this is going to be. Our experiences with acute leukemias have been difficult because it's hard to find a matched donor before the disease overtakes the dog. And that's really the one problem we've had with acute leukemias, is that the disease progresses so rapidly, as you know, that trying to find a donor and get the dog donors here can be really difficult. Having said that, we have transplanted a couple acute leukemia dogs who have done very well. One was cured of its disease. There was some debate about that manuscript. But anyway, that dog's home happy and healthy. One thing I wanted to point out to the listeners is that even if their dog is not cured, many times they have life extension over chemotherapy. And even if their dogs died, and I've asked every owner this about their feelings about their pets not making it, and to the T, all of them have said, you know what? We've tried virtually everything that is known to help our dog with this terrible lethal disease, and it just didn't work. And we go to bed at night sad that our pet died. We go to bed at night knowing that we did everything that we could possibly do for them. And literally to a T, everybody says that. Nobody's coerced them into doing this transplant process. They knew ahead of time, because again, we're very transparent, and they just feel that they've tried and it didn't work, unfortunately. It's the same in people. It doesn't cure all people either.
Yes, and those numbers are exciting, though, to hear. I mean, those are, much better than what we're seeing with chemo alone. So, yeah, that's really exciting what you guys are seeing. And I do agree. It's all about perception. Everybody's a little bit different. I know all the conversations I've had with people over the years with various cancers, some people's reactions are completely different than the room you just got out of, right? So I can see where you run into that too when it comes to, is it worth it or not? I think that's always a question, anything in vet med. But that's good to hear too, that clients that do this, because like you said, it's very committed people that are just wanting to know they did everything, that at the end of the day, they still feel good that they did everything they could, because they really did. I mean, if you do a bone marrow, you've done everything you can, in my mind.
Yeah, I would agree with you there. It's, again, not for everybody. It is expensive, but I'll tell you this story if we have a minute. The story that really got me hard in my heart was an owner in California when I was doing my residency at Davis. And I went in and gave the lymphoma talk. We should have a tape recorder to just play it or something, like a little podcast just for the owners, because we've said it so many darn times. And I did my talk, and he looked at me in my eyeballs and said, "Is that all you got? Is that it?" And I said yes at that point. And that's really stuck with me through this whole process. Even, in the beginning when we lost a few dogs in the hospital, that's what's always driven me, is that that's all we have. And it's not good enough for some people. So let's see if we can develop something else that could give these dogs hope. And so that's always been that guy's always stuck with me.
Oh, I think that's a great sentiment, and kind of we're sort of wrapping up a little bit here. So just lastly, I always like to ask, is there any emerging technology or anything on the horizon that you're excited about, that maybe it's in people and might trickle down to dogs, or something going on in dogs?
Well, I think we're all aware of immunotherapy in the human space being revolutionary at this point, although there are more toxicities, I think, than people imagined, and people that were thought, because they're more targeted therapies. But I'm hoping a lot of those will trickle down. We have a lot of, as you know, TKIs and kinase inhibitors that are becoming available. We have a monoclonal antibody against PD-1 now, which is a immune checkpoint inhibitor. So there is some stuff starting to trickle down, and I hope that those will make a difference. We're not probably talking about curing a dog. So I've always been so laser focused on curing a dog. I would say transplant right off the bat, but it doesn't cure all dogs. And again, it's not for everybody. So these products, I think, hopefully will really help dogs in the long term. I think we're all still trying to figure out how to use them, how to combine them, et cetera, as is in people. So I think the whole field of immunotherapy will make some changes for sure in our future. I'm getting quite old. I'll probably be retiring in the next 4 or 5 years. So maybe I won't get to see the benefit of that. Maybe I will. But anyways, I think that's going to be pretty exciting for sure.
And then I always like to ask, who would you recommend to be a guest on this podcast?
Well, that's a biggie. I don't know anybody who's doing something that's unusual. I stuck my professional neck way out when I did this, and I didn't invent transplant. I just took it from a research setting and put it in a clinical setting. But it was a bit of a gamble, I have to say. And so I would say that anybody out there who's putting their neck out a little bit and saying this is something that can work. And so, Cheryl London's been doing it for years. Doug Pham, Phil Bergman, when he came up with helped Sloan Kettering with the concept DNA vaccine for melanoma. Those are folks who decided that something needs to be done, and were involved in developing some alternative strategies. Like you said, we've been using CHOP for, I don't know how many years now, my whole career, which is 22 years, and it's probably used for 40 years or so. And so these are all folks who have been involved in trying to make a difference. And so any of those folks would be quite interesting, I think. It's never as they say in science, it's really never a eureka moment. It's very rare to go, oh my God, I'm changing the world. It's really science building on science, and kind of grudge, hard lab bench science to try to make a difference. And so it's nice to acknowledge those people.
Oh, totally agree. And I think this conversation has been so interesting. I love learning more about the transplants and what you guys are seeing. And I'm definitely excited to see how this transforms, especially in the public setting, the private practice setting. It'll be interesting to see how all this grows. So we'll certainly be watching closely. And thank you again, Dr. Suter, for being on this podcast.
No, I truly appreciate it. Thanks, Rachel.
Well, that's it for this episode of the Veterinary Cancer Pioneers Podcast. If you enjoyed this episode and gained valuable insight, we would be so grateful if you could share our podcast with your friends and colleagues. And it would be even more wonderful if you want to give us a 5-star rating, positive review, or any kind of feedback on Apple Podcasts or wherever you listen. The Veterinary Cancer Pioneers Podcast is presented to you by Impromed.